Good morning, everyone. Welcome to my channel, Vital Health and Dental. Today, we are going to study a very important topic, the periodontal pocket. What is periodontal pocket? Periodontal pocket is a pathologically deepened gingival sulcus. Now, what is gingival sulcus? Gingival sulcus, as you can see in this picture, this is the enamel of the tooth and this is the root part. Now, this V-shaped space, look where the cursor is moving. This V-shaped space, which is bounded by the tooth on one side and by the soft tissue on the other side, is called as gingival sulcus. This gingival sulcus, when deepens pathologically, is called as periodontal pocket. This is the most important clinical feature of periodontal disease. Now, this progressive pocket, it happens or by the destruction of the supporting periodontal tissues, and it leads to loosening and exfoliation of teeth. This word pocket, it comes from a French word pochette, which means a cul-de-sac or a pouch-like cavity. This periodontal pocket can happen in two ways. This gingival sulcus can deepen either by coronal movement of the gingival margin or by the apical movement of the junctional epithelium. Now, coronal movement of the gingival margin happens when there is bulk of gingiva. That is, there is increase in the gingival tissue. And this pocket lining, which is this junctional epithelium, when it moves apically, it leads to formation of the true pocket. I will explain it. First thing is classification. Depending upon the type of pocket, it can be gingival pocket, which is also called as false or pseudo pocket, or periodontal pocket, which is also called as absolute or true pocket. Now see, this was a tooth surface. In this, earlier it was healthy, but later on when there was abundance of plaque and calculus, along with due to any reason, it might be inflammatory reason, it might be drug-induced gingival enlargement, it may be due to some other medication, this gingival tissue has increased. Look, the epithelial attachment is there. It is at the same place where it was before. Epithelial attachment has not moved apically, but this gingival tissue has increased in size and it has led to the deepening of the gingival sulcus. So we will call it as gingival pocket. It is a false pocket or a pseudo pocket. It is not a true pocket. Now, how to differentiate this false pocket from true pocket? This one is which I am showing here is a true pocket. Now see the difference. I'll explain here. Junctional epithelium is at the same level where it is in the healthy tissue. But here in second picture, the junctional epithelium has moved apically along the root. That is, earlier the junctional epithelium level of attachment was here. Now the junctional epithelium has moved apically and it has reached to a point more apical on the root surface, which has led to deepening of this gingival sulcus. And now it is called as a true pocket. Okay. Now this true or absolute or periodontal pocket, it can be of two types. It can be a suprabony pocket or it can be an intrabony pocket. Now let's understand what is the difference between suprabony pocket and intrabony pocket. So first is suprabony pocket. Suprabony pocket is also called as supracrestal or supraalveolar. See, the highest point on the bone is called as alveolar crest. Okay, this alveolar crest, the pocket in relation to this alveolar crest is defined as supraalveolar or intraalveolar. If the base of the pocket, this is the base of the pocket, if the base of the pocket is superior to alveolar crest, see, this is the alveolar crest, and if the base of the pocket is at a superior level, that is at a supra level, then the alveolar crest, it will be called as suprabony pocket. Done? Now in this picture, see in the third picture, this highest point on the bone is alveolar crest and this is the base of the pocket. If I draw a line from base of the pocket to the bone, then the alveolar crest level is at a higher level. Alveolar crest is here. Okay. Alveolar crest is just let me draw it here. See here, this is the alveolar crest. Level of the alveolar crest done. Now this is the base of the pocket. Done. This is the base of the pocket. Now, if you will see, you can see here that it is base of the pocket is at a inferior level. Base of the pocket is at inferior level than the crest of the bone. So this type of pocket will be called as infrabony, intrabony, intraalveolar, or subcrestal pocket. I think this I have made it very clear that how this thing works. Now, coming to the next classification, that is based on the, I hope this was very clear. Now, based on the number of tooth surfaces involved, pockets, they can be classified into simple, compound, and complex. Now, look at this picture. This is simple pocket. We call it as a simple pocket when only one tooth surface is involved. Done. And the base of the pocket is in direct contact with the outer environment. This is called as a simple pocket. Like any of the tooth surfaces can be involved. It can be a buccal surface, it can be a palatal or lingual surface, it can be a mesial or distal surface. We call a pocket as a compound pocket when two adjacent tooth surfaces are involved. Now, listen to me carefully and give attention to this picture. See, I have told you that we call it as a compound pocket when two adjacent tooth surfaces are involved. This is important. Why this is important? Because when two adjacent tooth surfaces are involved, what happens that base of the pocket is in direct contact with the outer environment. Means whatever is present at the base, the pocket contents, they will be drained directly to the oral cavity or outside, and there will be no formation of, or there will be lesser chances of formation of an abscess, which is a case with the complex pocket. Now come to the complex pocket. In complex pocket, there can be involvement of two surfaces, but they are non-adjacent. Non-adjacent means that the base of the pocket is on one surface, then the pocket spirals around the tooth, leaves one surface and opens on the next surface. If you want to see it by example, let's, for example, the pocket has the base on the lingual surface. Okay, then it moves around the tooth, then it spirals around the tooth from the mesial or distal side and opens on the buccal side. So this will lead to what will happen in such cases. In such cases, the chances are that the pocket contents which are present at the base, they will not be drained. They will be getting accumulated, and there will be chances of forming an abscess. Done. I hope I have made it very clear. Now, this is the theory part. If you want to see that pockets can also be spiral, that is originating on one tooth surface and twisting around the tooth to involve the one or more additional surfaces. Now, based upon the relation to the crestal bone, suprabony pocket, intrabony pocket. This we have already discussed that suprabony pocket is its relation to the alveolar crest, that the base bottom of the pocket is coronal to the underlying alveolar bone, and in infrabony pocket, the bottom of the pocket is apical or inferior to the level of the adjacent bone. Now, what are the differences between suprabony and intrabony pockets? See, this is a suprabony pocket, this is alveolar crest, and the base of the pocket is superior to the level of the alveolar crest. This is the level of the alveolar crest, and the base of the pocket is inferior to the alveolar crest. In case of a suprabony pocket, if you can see the base, the pattern of bone destruction is horizontal. That is, the level of alveolar crest is at an angle of 90 degree to the long axis of the tooth. Done. That is the only way. When the bone loss is horizontal, then the pocket become suprabony. And in case of an infrabony pocket, there is angular bone loss. There is vertical bone loss. Now, what will be the angulation of the transseptal fibers? Just to mention here, what are the transseptal fibers? Transseptal fibers are the fibers of the periodontal ligament. They are the most superficial. Most superficial means when we open a tooth from the coronal side and we move towards the apical side, the first fibers which we encounter are transseptal group of fibers. These fibers are, as the normal English, it is transseptal. From one tooth surface, they are going to the other tooth surface. And they will follow the anatomy of the underlying bone. So in transseptal the fibers in suprabony pocket will be horizontal, and in intrabony pocket, these fibers will be angular. Now, periodontal fibers on the facial and lingual surfaces, they will be the same. Now, pockets can be further classified depending upon the nature of the soft tissue wall of the pocket. This is important. This is important. Why this is important? Depending upon the nature of the soft tissue wall of the pocket. This classification is based on the soft tissue wall of the pocket. Based on this, a pocket can be edematous and fibrotic. Now, what does it mean? As we all know that periodontal disease, it happens in an episodic manner. It is a continuous disease, but it occur in bursts of activity and inactivity. Whenever there is an active disease taking place, there will be the formation of the edematous soft tissue wall of the pocket. But whenever there will be inactivity, then this soft tissue wall of the pocket will become fibrotic and it will not show any signs and symptoms of inflammation. Like the edematous pocket will be, there the color, contour, consistency, surface texture, bleeding on probing, exudate, any pus or anything like that, there will be all signs of inflammation present because the disease activity is going on at that time. But in case of a fibrotic wall, for the time being, the disease activity has stopped and there will be no or lesser signs of inflammation. So based on the type of disease activity, the pocket can also be classified into edematous and fibrotic. That is, it is either active or inactive. Now, what are the clinical features of a periodontal pocket? Clinical features include, the most important clinical feature is most of the times is bluish red thickened marginal gingiva. It can be it can happen in the form of a bluish red vertical zone from the gingival margin to the alveolar mucosa. There will be gingival bleeding and suppuration. There can happen tooth mobility and diastema formation. There will be localized pain and a sensitivity of pressure. Patient feels the urge to dig into the teeth. Like patient has an urge to suck the material into the material from the teeth. Like patient might also complain of having the food sticks between the teeth, or there is food lodgement in the teeth. For that, patient has an urge to suck the material or to dig into the tooth. This is one of the most important clinical feature of periodontal pocket. Then there can be a radiating pain which is deep to the bone. The pain will be dull, it will be gnawing, it will be it is like sensitivity to heat and cold. Then the foul taste will be there. The only reliable method of locating a periodontal pocket and determining its extent is careful probing of the gingival margin along each tooth surface. On the basis of the depth alone, however, it is difficult to differentiate between a deep normal sulcus and a shallow periodontal pocket. I will explain what does it mean. It means that there can be a gingival sulcus which is deep, but it is healthy. It can be differentiated from a periodontal pocket which shows signs and symptoms of periodontal inflammation. I hope I have made it very clear. In the next lecture, we will carry on to the pathogenesis of the periodontal pocket and how the disease progress